All right, we're back. Hello. Um, Hi, everybody. Thanks for joining us again. So I just got a text from Dr. Serulle, and he's actually in the middle of the case. He should be done within the next 10 to 20 minutes. We will resume our webinar within the next 10 to 20 minutes. Dr. Serulle, just to give you a little bit more of a background on his training and how his affiliation with Northwell Health. He is the director of neuroendovascular surgery at Phillips Hospital. Dr. Serulle is also a member of the Department of Neurosurgery at Lenox Hill Hospital. He specializes in endovascular treatment of stroke, intracranial aneurysms, vascular malformations, I can't say that, atherosclerotic disease of the neck and head vasculature, and other vascular pathologies of the head, neck, and spine. So we're really excited to have him. He's going to lead us in a virtual OR for cerebrovascular surgery. Again, he's coming out of a case, so gotta love the fast-paced and unexpected world of neurosurgery. Before he comes on, I would love to just take this time to answer any questions that you may have about the Department of Neurosurgery at Lenox Hill Hospital. Feel free to use the chat or the Q&A for this, because I can monitor it better because I'm not doing a presentation. Yes, so in terms of the topics that are going to be covered, you can actually go to our BRAINterns website. There's a schedule with the names of all of the speakers and the topics that they are discussing on our website. So you can go to www.brainterns.com/register. I uploaded the schedule there so you can print it out. Good question. In terms of listing the program on your CV, that you can't say that you shadowed us because you weren't with us in person. However, you can, you can list this as like a virtual observership. You can't say it's a shadowing course just because you guys aren't here in person with us. Yes, we do offer shadowing opportunities. I wish that we could welcome you all here at Lenox Hill Hospital. We recently were notified by the hospital that we are no longer able to facilitate shadowing experiences unless it is a requirement for your program. If your school has an affiliation with Northwell Health and you have a rotation requirement, you can shadow us, but you have to come within that rotation requirement time. And then if you are applying for a program that requires some clinical exposure and shadowing experience, you can show us your application and proof that you are applying to the application and shadow us. So essentially it needs to be a requirement for a program that you're currently in or a program that you're applying to. However, if you want to get some great volunteer experience and exposure to a hospital setting, we highly encourage you to reach out to our volunteer services. I'm going to put their email in the chat. It's volunteerexperience@northwell.edu. You are welcome. Everyone's welcome to volunteer at the hospital. This is a great way for you to get some community service hours, to get exposure to being in a hospital setting, and to actually interface with patients and their loved ones. So you'll help, it will help you develop those soft skills as well that you don't necessarily get a chance to work on when you're studying all of your courses in pre-med and med school. So that's just as important as the technical skills that come with being a doctor. It's really important to be able to have compassion, connect with your patients, develop strong, meaningful connections with those patients so that they can entrust you with their care, especially when it comes to neurosurgery. So many conditions are, that we see come into our practice are life-threatening, and it's really scary for our patients. And to know that they have somebody who's truly a caring practitioner on their side is really, really, I think, what makes our practice special, because our providers are so adamant about fostering those meaningful, deep connections with their patients, and earning their trust, and in turn, trusting the patient that they'll entrust in our care. I have to ask about international students volunteering. I believe you can. But in terms of like visa sponsorship, we can't sponsor a visa unless you're an employee. And unfortunately, that applies to our clinical research fellowship as well. So clinical research fellowship is a fellowship that was actually created in honor of one of our patients, Jenna Chiavelli. Unfortunately, she passed away from a glioblastoma. But she participated in our clinical trials program, and we were able to help extend and improve her quality of life through those clinical trials. And her family was very, very grateful to us and has donated money towards a fund that will help continue our clinical research fellowship program. Essentially, it's a program where you can apply to work with one of our attending physicians and assist them in research projects throughout the year. You also get to shadow in the OR, shadow them in the clinic, so you get a lot of clinical exposure. We will be sending out information about the 2024-2025 Clinical Research Fellowship application in probably January, February of 2024. That will be posted on our LinkedIn channel. Speaking of which, I'm going to share my screen. I'm going to share my screen so you can see. Let's get social. I made this slide. I know some of the links are broken, so I will post the links for the Slack and Facebook channels in the chat, but we would love to stay in touch with you. So if you want to, stay up to date on all of the latest happenings at Lenox Hill Neurosurgery, and also about and just want updates on different educational opportunities, I highly suggest following us on LinkedIn. You can join the Slack and Facebook channels to stay in touch with your fellow BRAINterns. We're also on Instagram, Threads, TikTok. We love making TikToks. And we're also on Twitter, but who knows how long that's going to last. RIP. Thanks to Threads. And I also heard there's an app called Spill. Let's see. Yes, I can post the link to the website for BRAINterns. I can also post the website link to our YouTube channel here. The recording should be uploaded today. I apologize if you're not seeing them yet. I had to send them out kind of late yesterday because my day was a little bananas, and our amazing co-coordinator for our BRAINterns program, Quinn Verona, is uploading those for us. So thank you, Quinn. If you're watching this, you're an angel. I'm going to post the links. All right. When will the module for the certificate be available? So certificates, we're getting lots of questions about certificates. We will give you a certificate if you participate in our survey at the end of the webinar series. The survey will be sent out on Friday, July 21st, the last day of the webinar. So if you're not able to attend all of them, that's okay. But if you want a certificate, you must attend that last one to get the link to the survey. So be sure to tune in. It's going to be a great day. Yep, the curriculum's on our website. I'm going to put our website, www.brainterns.com. That's where you can find out information about registration. Click the link to the YouTube channel. If you go to register and summer 2023 schedule, it's in that tab. So that's where those resources are located. The survey is going to ask you about your experience during this webinar series, and we'd also love to hear ways that we can continue to improve and develop this program so that we can best serve you. We truly value your feedback. It's helped us in over the past couple of years to continue to grow this program so that we can present topics and contact speakers who are going to really resonate with you and help you along your healthcare career journey. Or if you're just here to like learn and want, if you're already in med school, you don't necessarily need to learn about the process. We just love to hear what your interests are. So that's what the survey is going to be about. The survey is not existent yet, so I will share. I promise there's going to be a link to the survey. You can't do it yet, so hold your horses. La 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 la. I'm trying to read. Oh, thank you, Joanne. No, we really appreciate your support. I'm sorry to hear that your child is going through this, and it's that's the reason why we continue to do what we do. Our patients are our motivation, and why we are continuing to search for safer, more effective treatments for brain tumors and other CNS diseases. Nobody deserves to be diagnosed with any of these conditions, and we really strive to remain at the forefront of offering our patients the best procedures and treatments available, but we also are very committed to uplifting the next generation of neurosurgeons and neurosurgical professionals. So whether you're pursuing if you're interested in clinical trials, that's a path you want to go down, we want to support you. If you want to become a surgeon, we want to support you. If you want to become a nurse, we want to support you, because each and every member of our team is integral to our to exceptional patient outcomes, and we just really are so grateful to be in the position where we're able to offer our expertise and to offer our support to you guys, because you are the next generation of great doctors, great nurses, great PAs, great MAs. All of you are you should be really proud of yourselves for pursuing this path, and we want to support you in any way that we can. The virtual OR is coming. Dr. Serulle is still in the OR himself, so I'm just vamping, but he will be on in the next 5 or so minutes. Thank you for your patience. Let's see. So again, unfortunately, for like the clinical research fellowship, we can't sponsor a visa for that particular fellowship. But if you are an international student and have a clinical rotation requirement, and it's a part of your curriculum, you're welcome to shadow us here at Lenox Hill Hospital. It must be a requirement for your program though, otherwise you're not able to shadow. So we've had to like crack down on that. It's not our policy, it's the hospitals. Again, we'd love to have as many of you as we can. So we're just really, again, appreciative of your interest to be with our team. That just because you can't shadow here doesn't mean you can't shadow at other hospitals. I highly encourage you to reach out to the hospitals in your local area, ask if they have any shadowing opportunities, observership opportunities. That's going to be a great way for you to just get some exposure to what it's like to be in a hospital setting, work for neurosurgical practice, and to just get your toes wet a little bit. So to be in clinical research, no, you don't have to go to med school. We actually, our clinical research team, we have who helps with our clinical trials. Some of our clinical research team members have degrees in medicine, but some don't. So it just kind of depends on like what type of clinical research you do. If you want to be like in the lab, yes, you will need to get a degree, probably biomedicine. But if you want to just like facilitate clinical research, if you study stats or something like that, that would be a fantastic asset to working in clinical research. Yes, Joanne, we're sending you prayers. And again, thank you so much for joining us. You are amazing. So, and again, our patients are why we do what we do. Actually, I'll share my own experience. So I actually went to school. Speaking of like, what do you need to major in to work in healthcare? Also my banks. I don't know what's happening, but I actually went to school for musical theater performance. I have grown up singing, dancing, acting, wanted to be on Broadway, and got my degree at the University of Michigan, moved to New York, was a professional actress for 3 years. And then I actually suffered a severe spinal cord injury. Go blue, woohoo, go blue. So I actually developed something called cauda equina syndrome. Some of you may know what that is. It's a very, very serious condition, and I had to undergo an emergency spine surgery. What inspired me to go into healthcare was actually not like this, like the injury and like being like, oh, I've learned so much about my body. It was the compassionate care I received from my neurosurgical team. I went to the emergency room by myself. And it was really a scary situation. I live in New York. My family is from Minnesota, so I don't have anyone here, but my doctor and all of the residents who took care of me made me feel so safe, made sure I knew what was going on, and just showed so much compassion that it did inspire me to pursue a career in healthcare administration and provide patients with that kind of support in an administrative capacity. So I hope my story inspires some of you who may be pursuing this career path but don't have a traditional background of like, I'm going to go to med school for healthcare, or I'm going to go to school for healthcare administration and pursue that type of career. There's everybody's path is different, and I'm happy to share that. I'm even though I'm not on Broadway, I'm happier than I've ever been, because this has just been such a fulfilling, incredible career. And it's really rewarding to be able to work with students, to be able to work with patients, and to learn from truly the most knowledgeable, incredible providers. So I just wanted to, again, I'm like vamping, so I thought I'd share my story. Oh, of course. But I hope that just helps some of you who are maybe, again, not on a traditional career trajectory, realize that it's okay. You can still, as long as you're passionate about something, work hard, seek out mentorship, and are willing to fail. That's okay. Like, you can do anything. I had a mentor say to me, fail means first attempt in learning. So, kind of back to our discussion with Dr. Wiley, if your grades weren't great at the beginning of your undergraduate journey, that's okay. That was your first attempt in learning, and you learned how to study more efficiently, how to seek help from mentors and from other students. Those are learning opportunities. Nobody's perfect, and it does take time to master all these skills. So, oh, you're welcome. Thank you guys for listening. Let's see, I'm going to check my phone because I'm getting texts from Dr. Serulle. Ha, he's joining now. Amazing. Hi, Dr. Serulle. Let's see, can you hear me?
Hello.
Hello, thank you so much for joining us. I was just vamping a little bit.
Yeah, I'm
And
so sorry. I'm a little late. We had a case and it went longer than usual, but
How dare you take care of your patient? No, I'm kidding. No, it's no problem at all. We're so appreciative of you being here and volunteering your time and sharing this virtual cerebrovascular OR with our students. I did give a little introduction for you at the beginning of this session, but I'm just going to reintroduce Dr. Yafell Serulle. He is the director of neuroendovascular surgery at Phelps Hospital. And he's also a member of the Department of Neurosurgery at Lenox Hill. He specializes in the treatment of endovascular surgeries, and he addresses different conditions like strokes, intracranial aneurysms, vascular malformations, and other vascular pathologies of the head, neck, and spine. So without further ado, I want to make sure you have plenty of time for your presentation. I'm going to pass off the spotlight to you.
Okay, well, great to be here. So, my specialty or my subspecialty is neuroendovascular surgery. I'm going to share my screen here. Let me see if I can get it here. Okay, and hopefully now you can see my screen. Can you confirm, Hannah,
Yes.
if we can see it? Okay, perfect. So,
Looks perfect.
That's me there. And, if you have any questions, of course, feel free to reach out to me by email or social media if needed. But, so the field of neuroendovascular surgery, to start, this is kind of like what our room where we work looks like. And the whole concept of neuroendovascular surgery is to treat vascular diseases of the brain, the head, and the neck using minimally invasive techniques. And to be able to use minimally invasive techniques, we need to use image guidance. So what you're seeing here, these are cameras based on radiation or X-rays. These are kind of like X-ray machines that are able to give us a real-time image of what's happening inside the human body, specifically inside the arteries. So the way we work, we put a patient here, we access their arteries either through the wrist or through the groin, and we use these cameras and these controls to navigate those catheters and wires into the patient's brain. And at every time in our operation, we are looking at this screen, which is what's coming from these cameras. These are pedals here that we could use to control, the pictures, and these controls here control the tables and allow us to manipulate the angles at which, we look at the brain. I'll show you a video very quick of what represents kind of like how we get to the brain. Very basic. This is a patient who has a clot in the left middle cerebral artery so that the blood cannot pass through. So that in the typical procedure, we would put this patient on the table, as I said. We would do a tiny little hole in the common femoral artery here. And this is the aorta. And, we are looking at every stage of this procedure through these cameras. We are advancing the wire and the catheter. This is the catheter. And then through this big catheter, we advance this smaller catheter that has a little hook, so that this little hook allows us to get into the aortic arch, which is this one. These are three main arteries that come from the aortic arch: the innominated artery, the left common carotid artery, and the subclavian. In this patient, we hook our catheter into the left common because this patient has a clot in the left middle cerebral artery. We advance our wire. This is the neck of the patient, as you can see. And we advance this catheter and wire into what we call the carotid bifurcation. This is now the internal carotid artery, now getting into the patient's brain. Now these are, for correlation, these are the eyes of the patient. So we are right here getting into the skull base. And then we are going to use a smaller catheter and a smaller wire to be able to get to the clot. And what you're going to see in a second is exactly that. As we get into the brain, of course, the cases get, more, you have to be more cautious because these are very small vessels. The diameter of this vessel is probably about 2 to 3 millimeters at the most. So as you can imagine, these are very, very tiny spaces where you have very little room for manipulation. But here we are engaging that clot. And what we typically do, we suck the clot or we aspirate the clot until it's completely gone. And that way we can restore, we connect that to a pump outside the patient and we aspirate the clot. And then that way we restore the blood flow in the patient's brain. So this is kind of like a summary representation of how, we do the cases. And talking about a stroke, I think a stroke has been one of these conditions that we have probably seen one of the biggest changes in all medicine, and has certainly played an important role in developing, or being a driving force in developing our field. And just as a little bit of perspective when it comes to stroke, if you were to have a patient with a stroke in 1994, in the early 90s, there was actually no treatment. So you had a clot in your brain. There was no treatment for that. In the mid 90s, an important medication got approved, TPA, which is a clot busting medication. And when that really came, it really revolutionized the stroke treatment, because at the time then we could have something to give to those patients. Now, that medication could only be given to a very limited subset of patients and could only work about 25% of cases. And it wasn't until 2015, so only 8 years ago, that we saw the revolution in stroke with the advent of the catheters and wires that can allow us to actually go in the patient artery and mechanically remove, those clots and give the patient certainly a better chance at, at getting, better. I'm going to skip a little bit of these things, but, making a long story short about a stroke, when we remove these clots, we're trying to preserve brain tissue, because once the brain tissue dies, it doesn't really come back. And this is one of the tools. We use aspiration, as I showed you, but we also use other devices such as a stent retriever, which can like hook into the clot and can allow us to retrieve the clot. This is a patient that we had somewhat recently. Here we're using a perfusion scan, and this scan is a specialized CT scan with contrast that tells us the amount of the brain that is at risk for dying. So if you look at here, this will tell you what amount of brain has died. And here it's telling us 0 cc. But here is telling us in green the amount of brain that is about to die, but that is still viable. So, here we have 157 ml of brain that is, at risk for dying. So, when a patient is having symptoms, we're able to do this kind of scans. We receive this report immediately in our phone so that we could act on it in a very timely basis if needed. So we brought this patient, when we saw that scan, emergently to the interventional suite. We put the patient on the table. We accessed the groins of the patient, and we saw that there were 2 occlusions here in the middle cerebral arteries. That's why there's very little blood getting into the brain. All of this is brain tissue here that you see, it's blank. There's no blood getting there. And these are the occlusions. This is us working as a team together and trying to navigate our catheters. As we can see, the operators are looking at the screen and navigating those catheters into the terminal carotid arteries. We advanced those catheters there. We aspirated the clots, and here you go. We have recanalization of these blood vessels. So you see on the prior picture, there was no blood going in any part of the brain. Now we see the blood restored. This patient did really well. So as I said, this patient just about 10 years ago probably would not have had much of a chance to making it. But yet with this kind of tools that we have nowadays, this patient just 2 days later is there, sitting hopefully comfortably in on his stretcher and texting his family, hopefully. I'm looking at the chat now, and that's great. We can make it quite interactive. And we have some questions. I'll try to answer them. So we have a question here in the group. Do the cameras constantly emit X-ray radiation and to get real-time image? Is this harmful for the patient surgeons? Great question. Yes, with the current technology that we have, these cameras are based on fluoroscopy and X-ray guidance. Now, the machines nowadays have gotten extremely, extremely good, and we're able to do these procedures with very, very little radiation. So basically, the answer to your question, there is radiation, but that radiation, because of the advancement and the progress that we have had with the machines and the engineering nowadays, is very limited. And moreover, we use a lot of radiation protection, and we monitor that radiation that we receive. So every operator in the room is wearing protection all the way from the head to the eyes to our bodies. All our bodies are completely protected, so that we basically eliminate most of the radiation that would potentially get into our bodies. And the field of radiation medicine in general has been with us for many decades, and year after years, we have become a lot better at preventing radiation. So great question. Next question, how do you guys choose to put it through the groin? Can you not do an open heart surgery? What's the reason you guys don't do that? Great question. But so basically, the main reason we do the groin, and nowadays we're using the wrist, is because that's as minimally invasive as it gets. You're doing a tiny little hole the size of the tip of a pen in the patient's leg or arm that you can close with literally a Band-Aid at the end of the procedure. That there's no way to compare that to any open surgical technique in terms of invasiveness. And when you mention open brain surgery, imagine opening the whole brain, shaving the head, all the hair, first of all, doing a major scar in the head, then dissecting the brain tissue all the way to get to the artery. That's going to take you probably a couple of hours at least. And then once you get to the artery, you would have to open the artery and have very little control on it. So making a long story short, with this kind of technique of going with a tiny incision, you can close with the Band-Aid, but most of all, you're extremely quick in getting to the vessel because you're going within the vessel. And literally within 10 minutes, you access the groin, you will be in the brain curing the patient. So there's the time component, there's the safety component. You don't have to dissect any brain tissue itself. You're going from within the artery, and there's the access component. So how long does a surgery take on average? Well, it really depends on the surgery and the complexity and so on. I will tell you that some of our stroke cases can last anywhere from 10 minutes once we put the patient to the table to a couple of hours in the more complex cases. Now, that doesn't mean that all the surgeries we do are 10 minutes. When we are treating other cases like aneurysms or arteriovenous malformations, those are going to be much longer procedures that can take sometimes 2 to 4 hours, depending on the complexity. How do you prevent busting the artery with the wire? Well, great question. That's why you train for many years to do these procedures. You have very little space, as I said, and I think that the bottom line is you have to use your judgment a lot, and you have to use your skills that you have, been training for many, many years. And it takes years to do this kind of thing. So yes, in the hands of someone inexperienced, there's going to be a lot of risk, but that's why you train. That's why you go to, many years of training to do this. How long can such a catheter get in an average adult patient when you are going? It depends. Some of these catheters can be about 125 centimeters. The smaller catheters are 156 to 165 centimeters. So you certainly need the length to get sometimes very distal in the brain. And remember, the vessels are not straight. They have a lot of tortuosity, especially as we get older, the vessels become more tortuous. And because they get so tortuous, they eat up some of the length. So you need a lot of length sometimes. Some question about the evidence of Montelukast. I'm not familiar with that. What I would tell you would be that there's a lot of research going on in neuroprotection, and I feel that the next frontier, particularly in ischemic stroke, will be neuroprotection. There are a couple of drugs right now in clinical trials that we are trying on these patients, but I think the next frontier will certainly be neuroprotection. How can we prevent the neurons from dying so that when we recanalized, the patients have a good chance of, having great recovery? Chances of the clots to come back. Well, that's important, because once we recanalize a patient, we want to make sure that there's no new clot in the patient. So the way to do that is that once we are out of the emergent situation, then we do an exhaustive research, an investigation into the cause of the stroke. And that's where the multidisciplinary team comes on board. We work together with our neurology colleagues, cardiology colleagues, hematologists, and so on, to try to determine where is the stroke coming from. The strokes can come from the heart. The strokes can come from the blood itself. The strokes can come from atheromatous plaques. And once we find out the actual etiology, then we can target with, tailored treatments for it, whether it would be a blood thinner or whether it would be a cardiology procedure to make sure that no more clots come from the heart, and so on. Some very good questions about the clots when we physically engage them. Yes, when you physically engage them, they can detach from the catheter. So if you look at that picture here, that let's say, in this picture you have a clot here. This can clearly detach, but with the devices that we have nowadays, we're able to really, get a good grip on them, and we are able to really, retrieve them. Procedures are done anesthetized or would ever be done awake? Another great question. So in thrombectomy, in this procedure specifically that I told you about, I would say that about 50% of cases, we do them with the patients awake. And the reason being a couple. First of all, with the patients awake, we can probably do it quicker. So we don't have to, spend any time intubating the patient and so on. Second of all, there's some data in the thrombectomy literature that when we do these cases awake, the patients have a better chance of recovery. Part of the reason being that when we put patients to sleep, there's some dip in the blood pressure that can compromise the perfusion of blood into the brain. So, when we could do it awake, we do it awake. That being said, unfortunately, some of these patients, as you may, know, these patients can be moving a lot. They are aphasic sometimes, meaning their speech is compromised and therefore their comprehension may be compromised, so it's very hard to tell them to hold still. So then in those cases, when the patients are moving a lot, we have no other choice but to intubate the patients and put them to sleep. So about half the time we do them like that. Someone is asking the recovery time for thrombectomy. Well, it's really depends on many factors, I think the main important factor for the recovery will be how quickly we were able to do the thrombectomy once the patients had some symptoms. In other words, how much time went by between the time when the patient had the clot in the brain, preventing the blood to come through the brain, to the time that we recatalyze. So the shorter the time period, the more likelihood the patients are going to have a great, recovery. And in the best case scenario, we see a thrombectomy and the patient's going back to normal right after the thrombectomy, literally. So, I'll tell you cases when the patients are having a massive stroke. They can talk, they cannot move one side of their body. We put them in the table, we take the clot out, and right after that, the patients are talking. They're moving, they're talking, they're telling me, their name and so on. But of course, in other cases where the stroke has progressed before we, do the thrombectomy, those patients are usually, spending several days, if not weeks, sometimes in the hospital with us. Let's see. I can either do a few more questions or show a couple more cases, but I'm gonna answer how you treat a ruptured artery compared to a blocked artery. Great question. The other kind of a stroke that we have, this is an ischemic stroke that I've talked about, and I'll actually jump to a case of an ischemic situation. One stroke we have, actually, I'll show you this case really quick. This is a case we had very, very recently. This patient was having symptoms on the right side of her body and was having transient symptoms, meaning the symptoms would come and go. I saw the patient in the office one day, right? And the patient would tell me, look, there are days that, I'm having a little bit of weakness on my right side. Sometimes I'm having word finding difficulty. I don't find words and so on. So we do a series of imaging studies, and we found that the left middle cerebral artery was severely narrowed. As you can see here, the artery is patent on the right side, but here on the left side, you have what we call a focal area of severe stenosis. And we took this patient for angiogram, and as you can see here, that there is a focal area of stenosis here. We did some quantitation. This is a quantitative MRA. It tells us the actual flow in the vessels of the brain. It's a very objective study to use, because one thing is to look at it and say, oh, look, it looks really narrowed. But another one is to use a specific technology, quantitative measures of these arteries that we use. And as you can see here, the flow here is 170 on the right, but on the left is only 66. So we know the flow is compromised. These are the kind of cases that, if we don't do something ahead of time, these cases can come back to the ER with a complete occlusion. So, we go further, and we also do some more quantitation, doing some, brain imaging, showing that there is lack of flow in the left side. As you can see, the right, you see all the flow, but on the left, you see some decreased flow. So we took this patient to angiogram with the goal of restoring that stenosis to the actual, vessel lumen, to the actual quality of the vessel. I'll show you the study. What you're seeing here is what we're seeing on the screen. This is the area of stenosis here. Here's the angio suite filming the procedure. We have access in the groin of the patient here. and then we keep all the lights off just because the screen looks better when the lights are off. Typically, it's going to be 2 or 3 of us doing these cases together just because you need some hands there. Typically, there's going to be 1, sometimes 2 attendings, and then we have usually a physician assistant with us, sometimes 2 physician assistants with us, and depending on the case, 1 fellow or resident. Here we're crossing that area of stenosis here. This is how the hands look like in the case. You have to be really careful and very accurate here, trying to go into the specific vessel, crossing the stenosis. And that's me here looking at the screen, but also feeling with my hands that there's a tactile component to it as you encounter resistance. And here we were able to navigate the very small wire through that area of narrowing. And now we are past that area of narrowing into the other vessels. So now that we have found our conduit, the next step that we are going to do right now, we are going to dilate that vessel with a small balloon. So remember, we're trying to open up a vessel that's narrowed. There's no clot here like the first case I showed you that is occluding the vessel. Here we have an artery that is narrow. So we are inflating a balloon. This is the person inflating the balloon right now, and we are seeing the balloon inflated right here. And what that balloon is doing is expanding the vessel. Once we have expanded the vessel, now we're going to drop a stent. This is an intracranial stent, and the role of this stent is keeping the artery open in a more permanent fashion. Because if you only do the balloon, most likely the vessel is going to narrow again. So what's happening now, we're deploying that stent so that we can keep that patient completely, that vessel completely patent. And now we are dropping that stent. And here we have dropped that stent. You can see the stent extending from here to here. And, this patient, then we confirm that everything is good. And this is the patient with flow restored. And if you can see before the case and after the case, I think most of you can appreciate how good the vessel looks here compared to how bad the vessel looked here. This patient was following our clinic, 6 months later. The patient was doing very well, and then 18 months later, the patient did really well. Some questions about this case. I see, why is she having only left-sided strokes? Great question. And the reason why she's having left-sided strokes is precisely because of that area of stenosis right here. That area of narrowing or stenosis is preventing the flow of blood into the left side of the brain, and the left side of the brain is then having recurrent strokes. A good case, this case is a case of intracranial atherosclerotic disease treated with an intracranial stent. Let's switch gears to hemorrhagic disease now. So we talked about ischemic disease. Now we have a patient with severe headache who's having hemorrhagic disease right now. And what you're seeing here, this hyperdensity, this is hemorrhage in the patient's brain. This is a non-contrast head CT. It's a picture of the head. When patients come to the ER with severe headache, the first thing that we need to do is to rule out what? We need to rule out that there's bleeding in the head. And this was a young patient, a patient probably, I think was in his 30s. Here we do a CT angiogram. Once we know there's blood, we need to know where is the blood coming from. And here we see a cluster of vessels we're going to be seeing. Look at this cluster of vessels. I'm going to show you again this. You see this kind of cluster of vessels here around the brain stem. Took this patient to angiogram. And what do we see there? We see what appears to be an arteriovenous malformation. I'll show you another view of this arteriovenous malformation. And it's a patient with what we call a ruptured arteriovenous malformation. You see right here, the nidus of the arteriovenous malformation that ruptured in this case. Arteriovenous malformations, we are born with these things, unfortunately, and they tend to manifest themselves either with seizures, depending on their location, with headaches, and in the worst case scenario, they present when they have ruptured. And usually these are young patients who have them. In this case, we need to find what component of the malformation ruptured. And in this case, you have the artery that's feeding the malformation has an aneurysm right here, very, very tiny aneurysm. So what we did, again, this is the vertebral artery, and this is the feeding artery to the malformation with a feeding artery aneurysm. This artery goes into a nidus, and the nidus then is drained by a draining vein. So how do we cure them? Again, we have the luxury of having tools nowadays that from the groin or from the wrist, we can navigate these tiny catheters and cure the malformations from within. So here we went with a very tiny catheter into that aneurysm that had bled and that was feeding the malformation. And how did we cure it? We cure it with glue, basically. Imagine crazy glue that you can basically push through this microcatheter. So once we have a location with here, we can push this glue material into the vessels, and that's going to shut off all these vessels there. I'll show you how the glue injection looks like. We have the catheter. We're filling the aneurysm right here with the glue. And then we keep on injecting glue. And we know that it's completely closed. And there's a point that the glue starts to reflux, which is telling me, okay, that means it's enough. I'm going to take the catheter out. Because of course, imagine that glue that you're putting comes here. You don't want it to be here, because if it comes here, you're going to occlude the vessel that goes into the brain. So you have to keep it within this area without allowing any reflux whatsoever. Again, details are very important in our field. We're dealing with very, very, very tiny spaces. A little bit of glue that refluxes here is going to give this patient a massive stroke. So you have to be extremely careful. Great question coming from someone here. Abhinandan Biswas is asking, what do you do if the aneurysm were to rupture during the procedure? Well, this is one of the most scary things that happen to us, to be honest. One of the main concerns that we have when we put this patient in the table, this young patient who had a hemorrhage, is that when we are trying to cure the aneurysm itself that we are curing, we would rupture with a catheter. Because if that happens, that's called a re-rupture, and that can lead even to the patient's death on the table. So how do we deal with it? First of all, when it happens, you're going to know it happens because the anesthesiologist is going to tell you, doctor, the vitals have suddenly changed. The blood pressure is very high right now. The heart rate has changed. Something in the vitals have changed. And, once they tell you that, something bad is happening. The next thing you're going to do a new run, and it's going to show you that the aneurysm has ruptured. You have to keep calm. That's the first thing. You need to keep all your calm in the world, because the last thing is that you lose your access. The most important thing in that moment is that you have access to that aneurysm, which means immediately you are gonna then close it with whatever material you have there available. If you have glue, you're gonna inject glue. If you have coils, which are metallic threads, you're gonna just put coils. Or if you don't have anything, if you have lost the access, then you can either regain access and put it, or put a balloon, an inflated balloon here, and wait for the blood to clot. That's what you do. You keep your cool, and then you close the hole that has rupture. But again, easier said than done. Takes many years of experience to get to a point where you can manage this kind of complications. But certainly, one of the complications we have to deal with when we do these kind of procedures. How much time do you have after the aneurysm ruptures to try to fix it? Great question. Hemorrhagic disease is a little different to ischemic disease. When we have a clot in the brain, we say we need to get the clot out as quickly as possible. And we are talking about minutes and hours. When an aneurysm rupture, we don't usually do it that quickly because there's no need to do it that quickly. We do it within 24 hours. And we want to make sure before we go in that a lot of other things are controlled. That if the patient needs an EVD to control the intracranial pressures and control the bleeding and the hydrocephalus and so on, that we control all of that before putting that patient on the table. So certainly with the ruptured aneurysm, we have a slightly more time than what we do with the strokes. All the aneurysm procedures, we do them with the patients sleeping in our practice, meaning all these patients go to general anesthesia and so on. Let's see, some interesting questions because I think we only have a few more minutes to go. One coming from Justice. Are there certain malformations that are inoperable to do? Yes, absolutely. There are some cases that are inoperable. Some very complex cases, depending on their location in the brain, depending on their size, the size that they have, that we just tell the patients, look, sometimes the risks of doing something are more than not doing something. And that's the reality in our field and in probably most fields in medicine, that sometimes you have no other choice but not to do something. So, certainly a possibility. Are there certain qualifications a patient must meet in order to proceed with the procedure? Well, I don't think necessarily that the term qualification is the right one, but yes, I mean, look, if we're going to put a patient on the table to cure a patient, at the very least, we need to know that this patient has a good survival. So, let's say in the case of a ruptured aneurysm, the patient needs to have a certain neurological exam, and the patient needs to have some stability, hemodynamic stability, before we put the patient on the table. It needs to be stable enough that we put the patient on the table. Because, if you're going to take to fix an aneurysm, you want to make sure that this patient is not going to suffer a major problem that's going to be separate to this, a heart problem, a heart condition, and so on. So you have to take care of some issues before certainly putting these patients, on the table. Could you tell a story of a complication that happened during a surgery you were performing? Well, there are many, to be honest with you. In our field, you have to leave understanding that yes, you are going to cure a lot of people, but because of the nature of the disease itself and the kind of conditions we're dealing in the vascular world, many conditions are going to have a very poor prognosis and there could be complication. There are some procedures that even have a big complication rate of like 10, 15, even 20%, sometimes you have to quote. So, I could tell you stories about those cases, but I think the bottom line is when you come into a field like this, you have to understand that, you are going to win some days, the patients are going to win some days, but then some days patients are going to lose. And, even with the best intervention that we could do, sometimes, the patients are not going to survive or will survive with significant disability. And of course, these things are compounded by the fact that you have families that are putting, a lot of trust on you. And, and you know, and it's you are the one, you are the face of the team in that sense, and you know, and you have to talk to them. Now, I think that as any surgical field or any procedural field, practice makes you better, and you try to do your best, you know. And you know what I've learned is that when you have a complex case coming, let's say, planning is key. I'd like to sit down days before the case, studying the anatomy of the patient, studying the potential possibilities that you're going to encounter the day of the procedure. Have a plan A, have a plan B, have a plan C. Really, you don't go into a case unless, of course, it's an emergent case. That's a different story. But when you have the luxury of time and to plan for cases, you have a lot of tools. You know, that's why we take a lot of pictures before, like this one, before ahead of time, so you can start planning ahead. And you even have 3D models nowadays, and you can even deploy you know, devices in a 3D model that can be reconstructed based on the anatomy of the patient itself. So for example, if I'm going to cure this aneurysm, and this is scheduled, let's assume this is a non-ruptured aneurysm that a patient saw me in the office for, and I'm going to schedule it in 2 weeks. I can send a 3D picture to a lab that's going to give me a 3D model, and I can use that 3D model to try certain tools, so that the day of the procedure, the day of the surgery, I kind of like have a really good idea of the problems I'm going to encounter and whatnot. So certainly, you know, we try to be as exact and try to use all the tools that we have, you know, in our hands to make this better. So I think it's 11 o'clock.
It
These are
is,
great questions.
unfortunately, I'm gonna
And
have to, yeah, we're gonna have to end this session with
of
Dr.
course,
Serulle. But thank you so much. This was so wonderful and informative, and I think I honestly, I don't know how you do what you do. This is crazy. um, crazy. And we're just so grateful to have you on our team here at Lenox Hill, and for all that you do for our patients. Thank you again, Dr. Serulle. It's been a real pleasure having you for this virtual OR, and we appreciate you making time for us on your busy day in between cases.
no, thank you, Hannah. Thank you very much. Great work, everyone. And congrats to all the students here. Keep it up. Keep it going. Thank you very much.
Thank you, Dr. Serulle. Take care.
Take care.
I'm going to quick end this meeting so we have a clear recording, and then we'll start the next webinar in 1 minute. Thank you so much, Dr. Serulle. Take care.